There were some interesting things that did come out of our study. One was the depression modality, and the way that we approached depression was utilizing something called the PHQ-2, which is basically a 2-question screening for depression. And it basically asks about feelings of depression as well as feelings of anhedonia. And it turns out that although only 15% of patients reported depression, 41% of patients reported anhedonia, which is highly consistent with depression as a larger scale. So it's really interesting how patients actually report their symptoms, but ultimately what we really gain from this is that patients really give an insight to us in terms of when they're ready to transition towards palliative care, when they're ready to transition to cessation of chemotherapy. And one of the things that we're looking to develop this is how do we best treat our patients, and then also how do we benchmark physicians in terms of what the best way to manage patients is globally. End-of-life care discussions can often be very difficult from both a patient standpoint and a provider standpoint. And one of the things that this tool allows is kind of a shift in paternalism, where the physician sits down and says, we're done, to more of an autonomy and giving the power back in the hands of the patient, for the patient to sit down and give you some insight and to say, I'm having these worries about my burden to my family, the pain that I'm exhibiting, the financial pressures, or even depression. No, that tool gives us an inkling that they're ready for that transition. So it really puts the power in the hands of the patient to help guide their global plan of care.